There are nine free papers to be presented today, one from Sweden, two from Canada, two from the United Kingdom, one from China, one from Egypt, and two papers are multi-center international studies. And those are the papers presented today. As you may well be aware, the incidence of hip fractures is on a rise, and in the United States only there is approximately 250,000 trochanteric fractures a year. Usually, those patients are older than patients that sustain neck of the femur fractures. And the more instability in the fractures usually corresponds to the most osteoporotic pattern of the bone. The cost of treatment of these fractures in the United States is approximately $10 billion per year. Majority of the fractures are happening in the patients who are older than age of 65, and 3/4 of these patients are women. Usually women who are taller, more susceptible to the fractures in a ratio of 2 to 1. As I mentioned before, age-wise, the fragility fractures do occur in patients who are older, and obviously there is a group of younger patients who are involved in a high energy type of activities. And fractures in these patients more comminuted, more of a substantially displaced patterns, and more of a patterns which are, as often happens, harder to treat, reverse obliquity type of injuries. There are many issues which are involved in treating these injuries. The medical issues are very important. They're a basis for us to go to the operating theater and to perform the surgery. And those are issues managed by our colleagues, internists and anesthesiologists, and they are obviously the basis for success of what we do. So we are responsible for all of them. Nevertheless, for obvious reasons, create on more surgical implications of these injuries. Timing and preoperative traction issues, those are factors that are, I'm quite certain, well known to you. Let's talk about technical aspects of the intertrochanteric fractures and the surgical technique, which are the essence of what we do. The conventional approach versus minimally invasive surgery, choice of implants, compression hip screw and slide plate versus intramedullary or cephalomedullary devices, the plate length, number of screws, gamma nail, whether it's short or long, the significance of lateral cortex of the proximal femur in respect to choice of treatment, compression screw placement, calcar replacement prosthesis, and more issues. All those are just surgical technical aspects which are relevant to us, and not all of them today. Remember to think simple and don't miss the basics. And basics is really everything in our world. We should remember the simple basic anatomy of the proximal femur, the appropriate relationship between the neck of the femur and the shaft of the femur, both in the coronal as well as the sagittal and axial planes. We also have to remember that with the age, the neck shaft fracture changes. And when we are born, it's around 145 degrees. And when we are older than 75, many of us would have a neck to shaft fracture of less than 125 degrees. And those are things to remember when we're trying to strike anatomical or different type of alignment of the fracture reduction. The number one issue is the classification. And classification has to be easy to apply. It helps to communicate. It guides our treatment, predicts outcome, and should be reproducible. There are multiple classifications around. And the most classical would be, and very workable, is the classification by Evans from 1949. And this classification relies and bases on stability and to a very substantial way on a calcar femorale, on a very important anatomical structure which is localized in the posterior medial aspect of the neck and proximal shaft of the femur. Those are examples of stable and unstable fractures. Stable fractures the posterior medial cortex, and after anatomical reduction can withstand physiological load without displacement. The unstable fractures are those that, despite realignment and appropriate fixation, will collapse under axial loading. So, calcar femorale, traditionally very important structure to consider, to assess, and to think about when we deal with these injuries. And the newer classification, especially AO and Orthopedic Trauma Association mixed classification, again relies on the stability, and it describes slightly differently fractures based on the obliquity and the degree of comminution. There is some confusion when we describe these fractures, and I have to admit, even though I've been doing trauma for some time, I sometimes go and see what's new there. And do I really look appropriately at the definition of the geography, of the morphology of the fracture? The intertrochanteric fracture versus pertrochanteric. How do they correspond to the AO OTA classification? What is the pantrochanteric fracture, which is really nicely described and introduced by one of the pioneers of the modern era or in this particular field. The issue of a lateral trochanteric wall became more and more important while dealing with these injuries. We didn't think about the lateral wall some 15 years ago. And it's here and to be considered and to be incorporated into the choice of our treatment modality. And Dr. Gottfried from Haifa, Israel, was the one who emphasized it again and again and again, and came with a very nice technology, percutaneous compression plate, where the issues are both mechanics as well as the biology in respect to the less dissection and less soft tissue preservation, as well as sparing of the lateral wall. Well, nothing is new under the sky. If you go to the Museum of Orthopedic Surgery near Chicago, you will find that there are plates of this kind have been made very long time ago. And the surgeons in the beginning of the last century were as smart as we are today, if not more, because they did not have as many diagnostic modalities and tools that we have today. The lateral wall has been studied and emphasized in many different studies, and this is really something that we should consider these days when we deal with these injuries. Unusual patterns of the fractures. Basicervical fracture. This is extracapsular injury, and if you read the literature and if you look into some of your own experience, if you have substantial experience by now, you will find that they might be associated with a vascular necrosis of the head of the femur. Reverse obliquity injury is a different type of pattern, and this is very unstable and requires a different approach from the implant's point of view, whether it will be intracephalomedullary device or fixed angle device. So those are the factors that affect the outcome: the bone quality, the fracture pattern, the fracture reduction. I do for as good fracture reduction, but not for any price. And obviously their studies will tell you that, not always the quality of reduction would correspond to the outcome from the strictly functional point of view. Implant design, implant placing. This is a patient who is 65-year-old on dialysis, mechanical fall, and fracture which appears to be reasonably innocent and two-part and can be well reduced and fixed. Nevertheless, if you follow this patient, you will see gradual, more medial displacement and medialization of the shaft and even further displacement. The implant design. There are so many factors to consider. DHS, cephalomedullary device, proximal femoral plate, the issues related to the lateral cortex, plate length, screws placement, placement, short to long nail, minimally invasive versus more conventional. All these factors are important factors to consider. DHS or cephalomedullary nail. Those are the two most commonly devices used these days in the management of these fractures. And you know, the compression hip screw and slide plate and control the impaction of the fracture. And the higher angles create more tendency for impaction. This is the basic. If you use the same device for unstable type of fractures, it ultimately may lead to the failure of the hardware and to the failure of the fixation. And for this reason, intramedullary sliding hip screw has been introduced. It decreases the implant bending strain. It has a potentially percutaneous way of using it, and can be used for more complex and more unstable pattern of fractures, as well as pathological fractures. And those are the basic mechanics that I'm sure you're familiar with in respect to the bending moment, et cetera, et cetera. So the simple trochanteric fractures can be treated either with DHS or gamma nail. Pertrochanteric fractures can be treated with DHS only if it has what I would call rigidation. A longer plate, more screws, maybe circlage wire around the medially displaced fracture, or obviously cephalomedullary nail. And we all know that the stress level for gamma is lower than for DHS in this type of fractures. We have two papers which deal with these exactly issues, and they will be presented, one from China and one from the United Kingdom. Gamma nail. Really, the father of gamma nail was Gerhard Küncher and his friend, engineer from also a shipyard in Germany, Ernst Paul. And the first patient they treated, it wasn't intertroch, it was more subtroch fracture, which actually failed initially, and they had to redo it. But this is where it goes, all the way back to late 30s. And we will have two papers dealing with this issue, one from Sweden and another one from... Is Dr. Bandari back? Sorry? Is Dr. Bandari back? Will he? I
don't think so. I think another author will take it.
Oh, okay. Short or long nails. In the United States, based on my knowledge and experience, we hardly use short gamma nails these days. And the reason is the fractures which may take place at the level of the tip of the nail. But we will have a couple of papers which deal with this issue today, and we'll see what the experts in the field tell us today. The lag screw positioning. This is fundamental work which has been done in Yale University by Dr. Baumgartner and his group. And this is an excellent tool today for us at the time of the surgery, as well as assess the results based on this very simple formula and measurement that can be done in AP and lateral view of the proximal femur intraoperatively and after the surgery. We will have two papers which deal with this particular subject. One with the DHS, where this particular measurement has been actually described and used, and the second paper by the group from Toronto, dealing with the lag screw position in a femoral head for cephalomedullary nail. The proximal femoral nail anti-rotational device. This is a relatively new device designed by the AO group and made by Synthes, which based on controlled impaction, increased contact area between the bone and implant, preventing and delaying, hopefully, a rotation, and minimizing risk of femoral head penetration. And we'll see in the following two studies if in this particular technology addresses these problems. Plates versus proximal femoral locking plates versus DHS. There are different plates which are designed for fractures in the intertrochanteric and subtrochanteric area of the femur, especially in the younger patients with the comminution. And there is a study from Egypt which will deal with this particular subject as well. So obviously all this is great, but nothing, as we know, hurts us more than our long-term results. And as Charles Dickens said, take nothing for its looks, take everything on evidence, and there is no better rule. So let's continue. We're not going to talk about other technologies. We don't have simply that much time. And thank you very much. And please, if you have any questions to ask me now, I will be more than happy to do so. And we will have more questions to the people that really will present you more scientific data. Thank you very much. No questions? No questions? Well, that's great. It means that the first paper that will be presented is by the group from Sweden, and I believe it will be by Max Gordon. And Dr. Gordon will be talking about a prospective cohort study on functional outcome in patients with trochanteric fractures after surgery with the short gamma nail.
Thank you. My name is Max Gordon. I'm an MD at Danderyds Hospital in Stockholm. I'm also a PhD student at the Institute. I'm here to report preliminary results on a prospective cohort study that we have done regarding functional outcome in patients with trochanteric fracture after surgery with the short gamma nail. We were interested in the outcome other than the healing of the fracture, see how the patients are doing, and we were mostly interested in how is loss of offset affecting this outcome, and is lateral pain an issue after this type of surgery. So our hypothesis is that the position of a healed trochanteric fracture affects the functional outcome and causes lateral pain if the screw is prominent after osteosynthesis with a short gamma nail. Methods. Inclusion criteria, we have trochanteric fractures, type A1 and A2, just 10% of the A1 fracture, which you see up to the upper right corner. All patients were operated with a short gamma-3 nail. We had no cognitive dysfunction in this group, and the patients were, of course, willing to participate. Our goal is to follow up 100 patients. Primary outcomes. We have looked at hip function measured by Harris hip score. Secondary outcomes have been health-related quality of life, lateral hip pain, ability to sleep on operated side. Physical examinations were performed by a physician, and all these data were gathered at least 1 year after the surgery. We also had radiological examination where we mostly looked at the anteposterior view, which you can see the measurements here on the picture. These interpretations were done by an independent observer. Statistics, we did regression analysis on our data. We used the following confounding variables: sex, age, fracture type, adequacy of reduction, and ASA classification. These are our sample characteristics. As expected, mean age of 80 years, body mass index 23, the expected dominance of females, and also mostly ASA class 1 and 2 in the sample. We started doing surgery with the gamma-3 nail 2008. We have since then performed 213 surgeries. And 54 of these patients have died, 61 had cognitive dysfunction, and 24 declined participation, mostly due to health issues. They felt that it was too hard to come into the hospital. That leaves us with 74 patients. 15 of these we have incomplete data. These are phone interviews without x-rays, lacking perioperative x-rays. And then we have another 9 patients which we have not yet examined. So our results are, we have split the group in those that have a high loss and offset and those that have a low loss and offset. There's a slight difference, as you can see, between the groups, but it's doesn't really matter when we do regression analysis for this. When we look into our main results, you can see the Harris hip score there. And you have the two groups, the low offset loss and the high offset loss. It's a large difference between the group. The mean difference is 12 points, and it's highly significant. When looking at the EQ5D, we could not see a clear difference, but there's a tendency. Maybe it will come out when we have the full sample. When we looked into the screw protrusion, we could see that a large group experiences lateral pain and seem to have some kind of issue there. And also a large group seemed to develop lateral bone mass over the screw. But when we looked divided into prominent or no prominent screw, we could not see any difference between the groups. We also saw that we had two radiologically unhealed fractures. These scored fairly average on the Harris hip score, and there was nothing strange about their results. We have not yet analyzed the patients lost to follow-up and that have declined participation, but we're planning on doing that. So our conclusions are that in the sample of patients without cognitive dysfunction, loss and offset affects functional outcome as measured by Harris hip score. We can also see that a large group experiences lateral pain, but there seems to be no correlation between the screw protrusion and our primary outcomes. We have some limitations to this study. This is a relatively healthy cohort. We had to exclude quite a few patients, and the more sick patients were unfortunately not able to participate. This is also a small sample size and an ongoing study. The clinical significance is we feel that it will be interesting to look into ways in this loss of offset, whether you should use different nails, plates, or where you should augment osteocentesis, I don't know, but it will be definitely interesting looking into this problem more. Mattsson et al. Did a study on DHS plating where they used Norian, calcium phosphate, as an augmented osteocentesis and saw that there was less compression. Thank you.
Any questions? Any questions from the audience? Yeah, please.
Well, we looked at the perioperative pictures, measured, as you saw on our measurement, how far out the screw was, and then we simply calculated the compression, how much it compressed. So it's not a perfect measurement, but we feel that it showed pretty clear that the more it compresses, the more loss in Harris hip score you have. We took the median and then we split the ones that had higher and the ones that had lower. So we had 25 in each group, just split it in half. So I think, if I remember right, the loss was 11 millimeters. That differed the two groups. Well, above 11 and below 11, that is. So, yes? Well, I've fiddled around a little with our numbers, and I couldn't see anything indicating clearly that I was thinking maybe a low body mass index gives more protrusion because you have less fat, but no, it doesn't seem to be a big factor. But this is also a very, very small sample size, so I wouldn't be too definite about it.
Thank you.
Thank you.
Now we're going to listen to 3066 consecutive gamma nails, 12 years experience at a single center by Alicia Boyen, Kleimel, Andreas Beitling, Gilbert Taglang, Carl Ekholm och Anders Jönsson.
Good afternoon, ladies and gentlemen, Mrs. and Mr. Chairman. I have today the pleasure to present to you the study of 3066 consecutive gamma nails treated at the single hospital during 12 years. The study has been conducted in cooperation with Stryker Company. The intramedullary nailing has been present alongside the plate fixation for trochanteric nail fractures for over 2 decades. But still, it raises some concerns about its clinical value. The authors think that the intraoperative and later nail is still an argument for favoring the plate. Some point out that there is no convincing evidence for its benefits, and recently there has been a pejorative and very emotional comment published in JBJS. So in order to show that gamma nailing or intramedullary nailing is a safe and effective method of fixing the trochanteric fractures, we assessed a uniquely large consecutive data group at its originating hospital, thanks to Dr. Taglang and the CTO in Strasbourg, France, who gave the access to the data. We could analyze the complications versus design changes over time, and it gave us also a to determine and describe the epidemiology of this representative group. So we conducted a retrospective study of 3,066 consecutive patients, all treated with gamma nails between 1990 and 2002. The fractures treated ranged from basocervical through trochanteric down to diaphyseal ones. And the epidemiology, complications, fracture classification, and positioning of the implant in the bone were assessed with help of all available notes, X-rays by single observer within 4 months. The statistics were performed with help of SPSS program, and since this distribution was skewed, the non-parametric tests were used. So to the results, the 3/4 of a patient, and the median age was 81. The most common fracture cause was a simple fall, followed by high energy trauma and other causes. Standard gamma nail, the first generation, was implanted in 1,623 patients, followed by trochanteric gamma nail, introduced in 1997. Long gamma nails were implanted throughout all the period, and 37 other gamma nails were implanted. We could capture an interesting difference in fracture cause in men and women, where men had more high energy trauma at a younger age, with the fragility fractures increasing at the age of 60, 70, whilst women were almost not present in the high energy group at the young age, but there was a dramatic increase of fragility fractures after the age of 60 and 70, and this difference can be seen on this graph. Fracture classification was gathered with help of AO system, and for this representative group, we have a typical distribution of all the fractures classified. To the complications. The most common intraoperative complication was the distal locking. Still, we saw a significant decrease in this complication after the introduction of the carbon targeting device after 1993 for short nails, which dropped to 1.1%. We had 17 intraoperative fractures and 16 other complications. So, the cutout was the main postoperative complication, 1.85% by infection and healing problems, whilst the femoral shaft fracture was not very common. We could also show that the second generation gamma nail, TGN, had significantly less postoperative complications. We are aware of the big limitation of the study, a retrospective character, but still the consecutive large series add to the value and the quality of the study. We saw a low complication rate compared to the literature and significantly less complications with design changes. Still, cutout remains the main complication in these fractures, whilst the implant-related femoral shaft fracture is of a lesser problem, which was pointed out by Bandari in his recent meta-analysis. If we compare the risk of femoral shaft fracture for those implants, nailing nails and plates, but respecting the periods of design changes, this difference does almost disappear with newer implants. There is also a time factor. So, conclusions. With these 3,066 consecutive patients, we could show that the use of a gamma nail is a safe method, and this question whether to nail or to plate certain fractures should be left to the surgeon himself. Still, we see need for further investigation. We need to understand the mechanism of cutout complication. We need to still assess the new implant designs, the third generation nail implants, and to set better guidelines for modern osteosynthesis of the trochanteric fractures. We do need comparative studies of good quality, which are well powered. So to read more about the details of the study, I invite you to have a look at BMC Open Access Journal. Enjoy and thank you.
Okay, thank you, Alicia. I think there are some questions. Please go to the microphone if you... Yeah.
Would you be kind to come to the microphone, please? Yeah, thank you.
Have you come to understand any regions whatsoever about the cutouts? Any conclusions as yet?
The cutout and?
Any region that have come to your mind up until now? Have you drawn any conclusions about the cutout, any region whatsoever until now? Any region you have come to understand? No.
No, I'm sorry, I just didn't get the question.
I didn't get the question either.
You said you'd like to know what was the reason behind the cutout.
Yes.
Have you come to do any conclusion as yet, any firm conclusion whatsoever yet?
Well, biomechanically, we know that the screw doesn't collapse only in varus. It's a three-dimensional movement of rotation, two rotations, translations, and so that's why we are just about to, we have initiated a radiostereometric study evaluating the three-dimensional movements in the fracture and nail system to characterize the movements and to be able to know how we can avoid them.
Did you measure tip to apex?
Not in this retrospective study. I found the quality of the X-rays not sufficient to do it. I evaluated for maybe 300, but it was not enough to see the significant difference if there is or not some cutout risk for.
What angle of the screw and nail did you use?
We used, well, all the angles from 125, 30. Yes, so, but the 125 was the most common one.
Okay, in order to keep the time, get just one more question, and then we have to move on.
Do you make DEXA scan before or later after operation? It is the mention. Do you measure the osteoporosis? No. Please, please, a little
I tried
bit.
to measure.
And to protect the further fractures, fracture risks, it's very important to give medicament therapy.
Yes.
After that, do you do at your patients? Because I see that you are treated 3,066 patients.
Yes. Well, the osteoporosis treatment, I tried to do it with the Singh index, but again, I didn't find it very reliable. And I was not recording the osteoporosis treatment data in this study. As it was retrospective, we didn't have this possibility.
Because after first fracture, we wait another fracture in the next year.
Yes.
It can be on the vertebral spine and so on. Do you make X-rays of the spine?
Yes, we saw that 10% of our patients had contralateral hip implant already, so 10%.
Nevertheless, very important remark, we shall perform the secondary prevention, of course. But now we have to move on.
We have to move on, guys, sorry. The next paper is from the United Kingdom, and it's a tip to apex distance in DHS fixation, an audit of practice at the District General Hospital to be presented by, I believe, Dionysiosis Trikilidas and by George Murphy. Thank you.
Good afternoon. I will be presenting an audit that we did in our hospital in Milton Keynes, UK on the tip to apex distance. And a bit of background information to start with. As we're all aware, DHS is still a widely used device for fixation of trochanteric neck-of-femur fractures, and a recognized complication of this device is the screw cutout from the femoral head. In 1995, Baumgartner et al. Showed that tip to apex distance is the most reliable predicting factor of a screw cutout, and in general, a distance of 25 millimeters or less is a predictive of a good, successful result. This is a schematic trying to explain what the tip to apex distance is, and it's essentially the distance from the tip of the screw to the apex of the head in both AP and lateral aligned for magnification. So the aim of the study was to assess the position of the lag screws in DHS performed in our hospital and see if the TAD principle is put into practice. So we started our audit retrospectively, and we used theatre logbooks to identify all patients that underwent DHS fixation over a 4-month period. And then we studied their intraoperative radiographs and calculated their tip to apex distances. And the results were then presented in our departmental meeting, and awareness of the tip to apex distance principle was raised, and the importance of this principle was emphasized. We then did a second audit about 3 months later following the same methodology. So the results from the first audit cycle showed that there were 38 patients that underwent ablation. 2 were excluded because the images were not available. That left us with 36, out of which 9 were male, 27 female, and the ratio of right to left DHS was more or less 1-to-1. In the second audit cycle, we had 33 patients that underwent DHS fixation. 2 were excluded, again because the images were not available. That left us with 31, 6 males, 25 female, and again the ratio was right to left was nearly 1-to-1. So this table shows, summarizes the results of the audits. As we can see in the first audit cycle, there were 27 patients with a tip to apex distance of less than 25 millimeters, and 9 with more than 25 millimeters. And out of this 9, 3 went to cutout. On the second audit cycle, we had 26 with a TAD of less than 25 millimeters and with more than 25. And we did not have any cutouts in this group, but there was one cutout on the less than 25 millimeter group here. These two pie charts show how the cases with a TAD of more than 25 millimeter were reduced from about 25% to 16%. And with regards to the cutout screws, again, as I already said, in the first audit we had on the group with more than 25 millimeter tip to apex distance, we had 3 out of 9, which equates about 33%. And in total, there were 3 out of 36, 8%. In the next audit cycle, we did not have any cutouts in the above 25 millimeter group, and there was 1 out of 31, which is 3%. So some discussion points. During the presentation in our department meeting, it became apparent that proportion of trainees were not actually familiar with the tip to apex distance principle, and many believe that the ideal screw position is inferior in the AP and posterior in the lateral view. Others opted for a faster operation as they thought that DHS is a forgiving device. And from our results, we can see that from the second audit cycle, by simply raising awareness and emphasizing the importance of the tip to apex distance, we can reduce the cutout rates and reduce the TADs. We reduced the tip to apex distance to more than the cases with tip to apex distance of more than 25 millimeters from 25% to 16%, and we did not have any cutouts in that group. The one cutout that we had from the group with a less than 25 millimeters, we attributed to other factors that also can affect DHS failure, such as bone quality, patient's age, fracture pattern, and inadequate fracture reduction. The limitations with this study, it's a small study with very small numbers, and a t-test of the TAD means between the two audit cycles was performed, which showed some difference, but did not reach statistical significance. Recommendations that we can conclude from this study, raising awareness and emphasizing the importance of tip to apex distance can lower the cutout rates in DHS. It's a principle that should be regularly emphasized in orthopedic trainees, and we should be paying attention to the tip to apex distance during surgery, as it's the best predictor of outcome. And that's it. Thank you.
Thank you. Any questions?
Congratulations.
Thank you.
Isn't it so that you have simply made people more aware of how to be precise about what to do? And since you can't show that it's the tip apex distance that differs, aren't these related to other issues?
The primary reason for this audit was actually to see if the tip to apex distance is put into practice, and but during the presentation, it was found that about 50% actually of our trainees were not aware of it, and these are the people that were actually performing the operations. By raising awareness of the actual tip to apex distance, we managed to reduce some of the cutout rates.
But you haven't shown that it's the tip apex distance that matters here.
Nothing else.
The power has no statistical significance.
I
mean,
understand
there's not
that.
power for that.
Sure.
They're
small.
Yes, and the percentages appear large when you present them, 26% versus, but they're too small in numbers.
I understand this is one of the limitations we have in the study. So in order to sort this out, you can do an audit over a larger period of months, or even better, to combine audits from other and do a multi-center audit.
Yes. Thank you.
Thank you very much.
Okay, thank you.
The next paper will be Functional Outcomes Following Intramedullary Nailing of Trochanteric Hip Fractures by Mohit Bandari, Alicia Boyan, Kalle Kolm, Ulle Brink, Antoni Adili, Sheila Sprague, Nasir Hussain, and Anders Jönsson. A truly international paper, and we will see Alicia Boyan again.
Hello again. I have the honor to replace Dr. Bandari, who couldn't come to this meeting. So the following public presentation continues the theme from my first talk about the need for more comparative study of good quality, which are well conducted. And before performing multi-center randomized controlled trial comparing nails and plates, we wanted to make a pilot study to assess the feasibility of such an ambitious and big project. So we all know that the clinical trend in trochanteric fracture treatment has been challenged by the increase of nail fixation, and this is clearly shown in the recent analysis of Anglin. And even here at Sahlgrenska Hospital, we've seen the shift to nail fixation over 4 years. And the authors conclude that this shift resulted in higher implant costs without any benefits for patients. So that's why it is important to perform the highest quality study to deliver definite answers to these questions and determine if the intramedullary nailing could be a standard technique for certain fractures, trochanteric fractures. So why the pilot? We wanted to assess the feasibility of a large multi-center trial and estimated the pivotal study size, assess the surgeon's adherence to the protocol and patient's compliance and other organizational problems. So within 1 year, we recruited 85 patients and randomized them to DHS or gamma-3 nail at 3 centers here in Gothenburg, in Denmark, and in Canada. We included A1 and A2 trochanteric fractures according to AO classification. The patients must have been able to walk and must have been mentally intact. We followed them for 1 year. So our primary outcome was the revision and complication rate in the fracture healing, and function was the secondary outcome, measured with EQ5D, Med-Levinier score, and Parker mobility score. To the result, we lost 31 patients after 1 year, 35 and 5%. More or less half of them died, and there were other problems. Complications, we had 8 complications, 11.6%, 5 in gamma nail and 3 in the plate. 1 femoral fracture occurred after a fall, 4 revisions due to non-union and implant cutout, and 3 infections. Still, the revision rate and the complication rate was not significant in the groups, neither was the fracture healing. But if we look at the function, the statistical tendency favored the gamma nail at 6 and 4 months. We saw there's some interesting difference. So that's why the hypothesis for the study will be that patients operated with gamma nails have significantly better functional outcome. We analyzed the power of the pivotal study. We want to have 700 to 800 patients, and considering the dropout 1,100, we would like to include the mentally impaired patients, and we have to reduce the questionnaire load and also the follow-up to 2 visits at 4 and 12 months. We will use the Jensen-Mikkelsen and AO classification simultaneously, and also the Sahlgrenska University HIP score for acute outcome directly after the operation. So we are convinced that it is possible to perform the highest level of evidence-based medicine in the field of treatment of trochanteric fractures to basic questions and to set the guidelines for the modern care of patients with trochanteric fractures. Thank you for your attention.
Do we have any questions from the floor? Yes, Professor Waddell?
Thank you. Interesting concept. Is this a sponsored trial?
It is sponsored by Stryker, yes.
Okay, thank you.
Didn't mention.
What about subgroup analysis? I think that putting all the fracture types together is like the femoral neck fracture. We don't consider the same implant for the undisplaced and the displaced fracture.
Yes, well, we include the fractures which can be also treated with dynamic hip screw. We treat the A3 fractures with plates. So, of course, we will stratify the outcomes. And what I thought of also is, what about the functional outcome and the golden age patient that our German colleague mentioned yesterday? The patients are getting older, but also they have really high demands on activity. What about putting some age groups in the study and maybe showing that the function in these younger patients with a gamma nail is maybe better because it's a short, quick procedure, minimally invasive, and these are the hypotheses.
I suggest that you use a physiological score, not chronological age.
Yes, the biologic age.
Any plans about the cost analysis? Because I think there's the issue nowadays. You can perhaps reach the same results with these two implants, but we still have a large difference in price. What do we get for that extra money?
Yes, this is actually our Swedish dream here to perform such an analysis. Nobody knows, I think, at the moment how really what is the difference and how much these patients, how much resources this patient demand, and but this will be not this study. I think it's much more complex, and especially with this very multi-morbid patients, it is difficult.
No more questions? Okay, thank you.
Thank you.
Thank you.
The next presentation is a comparison of the proximal femoral nail, anti-rotation, and the dynamic screw for unstable proximal fractures. A randomized controlled trial from China by Doctors Guo, Yang, and Tang from the Suzhou, China.
And good afternoon, ladies and gentlemen. It's my pleasure to present here. My topic is comparison of the PFNA and the DHS in unstable proximal femoral fractures. As we all know, with the age of the, as we all know, because of the hip fracture is increased, the epidemiology and the incidence of hip fracture is increased because of the more people become elder, and the best method to treat the unstable proximal fractures, femoral fractures, is still controversial, and there are already of the extramedullary, extra and intramural is still controversial, as we all know. There are DHS, however, there are many complications, and intramedullary includes gamma nail, and also there are some problems in these fractures. So between 2006 and 2007, we do a randomized and prospective trial. More than 100 and unstable trochanteric fractures were included, and the male 16 patients are male patients, and also 68 female patients. And our group is a relatively young group, and the average age is about 42 years old.
And we treat PFN in 68 patients and DHS also in 68 patients. There are some problems about my slides.
Where's Christopher? Is Christopher here?
Sorry, there are some problems about my slides.
Yes, Christopher is here.
This is not my slides.
Looks good though.
Okay. In summary, the operative time and estimated intraoperative blood loss of PNA were significantly less than DHS group, but the use of DHS was associated with much less radiation time. And the patients who had PFNA had, on the average, significantly better mobility at 3 and 6 months post-operatively. And this difference was no longer seen at 12 months. We mean the Park mobility score post-operatively, the PFN group is much better than DHS group. Also, this the mobility score is better 3 months and 6 months post-operatively. However, 1 year post-operatively, the mobility score are similar in both groups. So this difference was no longer seen at 12 months. And our results suggest that the use of PNA may allow faster post-operative restoration of working ability in young patients when compared with DHS. And I'm very sorry, there are some problems about my slides. No, this is my slides.
Thank you, Ivan. Any questions? I do have a question to you. You rather have very young population in this group.
Yes.
And if I may ask you, what's the nature of this type of practice and the mechanism of injuries this patient sustained?
The mechanism of injury is because of the traffic and the falling injuries in our group.
So this is a trauma center population?
Yeah.
Did you classify these fractures in a more...
all our fractures are on AO type 31 and A2 and A3 types.
31-3?
Yeah.
All fractures?
Yeah, A2 and A3 types. We do not use an A1 because we think DH is the golden standard to treat this this group of fractures.
Thank you.
The next paper is from United Kingdom, intramedullary fixation with a third-generation nail versus the sliding hip screw for trochanteric hip fractures, a randomized trial of 600 patients with Niklas Jagodinski and Martin Parker.
Thank you. Good afternoon, ladies and gentlemen. My name is Nick Jagodzinski. I'll be presenting the results of a large randomized trial of the Targon proximal femoral nail versus the sliding hip screw for treatment of trochanteric hip fractures. I'd like to thank my colleague Martin Parker for the opportunity of presenting his trial, which he started whilst I was still at medical school. We included all patients of all ages with any trochanteric hip fracture, as classified here by AO, including type A3 fractures, so long as there was no subtrochanteric extension that required a plate longer than 5 holes for fixation. We also excluded pathological fractures. Randomization was done by way of a sealed envelope. All operations were either performed by my colleague Martin Parker or directly supervised by him, and both groups underwent the same post-operative care protocol with immediate mobilization and full weight bearing. At about 6 weeks from discharge, all patients were reviewed in a hip fracture clinic and seen by a nurse observer who was blinded to the treatment group. Thereafter, follow-up was by phone call at 3, 6, 9, and 12 months. Patients in both groups were treated on a traction table with an image in bio. Patients in the sliding hip screw group all received a standard 4 or 5 hole plate, which was supplied by Aesculap as Targon. Mr. Parker prefers to use a small incision approaching the proximal femur posterolaterally. Patients in the nail group all received a standard short Targon proximal femoral nail via 3 small stab incisions. The Targon nails are all solid, uncannulated nails of uniform diameter with a lag screw into the head, allowing for up to 30 millimeters of axial compression through a lateral barrel. The construct is strengthened with an anti-rotation screw superiorly, and dynamic distal locking is performed through the same jig. So here are a few demographics from the study that show that 300 patients in each group were well matched for age, sex, independence, and fracture classification. When comparing the operation details of the 2 groups, nailing took an average of 3 minutes longer to perform and required almost much X-ray screening time, although it's worth noting that as the study progressed, the nailings got quicker with less X-ray time required. Intraoperative complications were increased in the Targon nail group, with 13% of patients having the distal locking screw miss the dynamic hole at the first attempt, and that was despite using the jig. The femur only needed to be reamed on 4 occasions to allow insertion of the 10mm solid nail, and both groups experienced difficulties with lag screw insertion, although more so in the Targon nail group. Postoperative complications occurred in both groups, with no statistically significant differences between either group. Postoperative complications, both groups developed a small number of superficial wound infections that resolved with antibiotics. There was 1 case of deep sepsis in the sliding hip screw group that required removal of the implant. There was a trend to less fracture healing complications with the Targon nail. Lag screw cutout occurred in both groups, but the sliding hip screw group also witnessed 4 plate detachments. There was 1 episode of non-union in each group. There was an insignificant difference in numbers of patients requiring reoperation between the 2 groups, with 2 Targon nails out of 300 that needed revising compared with 9 in the sliding hip screw group. When I wrote this talk several weeks ago, there was a significant difference, but we've had 1 complication in the nail group since, unfortunately. Looking at the reoperations in the sliding hip screw group, the 4 plate detachments were all revised successfully using a med-off plate. Out of the 3 cutouts, 2 were revised to a total hip replacement, as shown in the top 4 pictures. The other one was revised to a med-off plate that became septic and was later converted to a girdle stones, as shown in the bottom 4 pictures. 1 lag screw broke in the sliding hip screw group following non-union after 1 year, which required revision to a cemented hemiarthroplasty. Looking at the reoperations in the Targon nail group, there was 1 case of cutout after non-union of 1 year that required revision to a cemented hemiarthroplasty. There was another nail that cut out and 1 case of non-union, but both patients were too frail and refused further surgery. 1 patient fell 18 months post-op and sustained a periprosthetic fracture around the distal end of the nail, and that was just a few weeks ago. 2 patients required procedures under local anesthesia. In 1 patient, the barrel of the lag screw backed out as it hadn't been screwed into the nail properly. This was reinserted easily under local anesthesia. And in another patient, the lag screw climbed into the joint due to micromotion at the fracture site, causing it to rotate. Again, this was easily retracted under local anesthesia. There was no statistically significant difference in mean length of hospital stay, including readmissions, and there was no significant difference between mortality rates either. Anatomical restoration was clinically assessed by a nurse blinded to the treatment group at the first outpatient clinic, and again, there was no significant difference between the 2 groups. Our blinded observer also assessed the pain scores of each patient using the Charnley scoring system, and again found no significant difference. However, when mobility was assessed using Martin Parker's own validated scoring system, our blinded observer found statistically significant better results in patients treated with the Targon nail, although it's worth noting this was only by 1 point on a 9-point scale, so might not have been clinically so significant. So in summary, there are pros and cons for the use of each implant. The sliding hip screw is a slightly shorter operation with fewer operative complications, even when you become an expert nailer, and it costs about €250 less than the Targon nail. However, the clear advantages of the Targon nail are that there are fewer fracture healing complications, fewer revision operations, and significantly improved. Thank you for listening.
Do we have any questions? Okay, congratulations to this. Sorry, we have a question. Okay.
Hello. Just wondering, for the nail itself, the Targon nail, the entry point for that is a trochanteric entry point, is it?
That's right, yeah.
And would there be any times, for example, if there's a lot of comminution in the trochanteric area, that you wouldn't use it?
No, he would use it pretty much with any type of fracture pattern.
So even if the lateral wall's completely blown out, you'd continue with the nail?
Well, that's right,
if
yeah.
it's randomized to it.
In a way, it makes it even kind of more important to use intramedullary advice to be in this patient group if the fracture's slightly less stable.
Right. Thank you.
Okay, congratulations to this very large material. We
Thank you.
really envy you. Still, as Mr. Parker himself states in the Cochrane reports, we are supposed to make subgroup analysis. I'm there once again.
That's right.
Do you have such plans, or will the power not be sufficient? We know that the A3 should not be treated with a sliding hip screw. The A1 perhaps.
Yeah.
Sure.
Martin Parker's previously published a paper suggesting that he prefers sliding hip screws. Since this one, he actually now prefers nailing, and his recommendations are that if you're going to be doing a lot of hip fractures and you're going to become an expert at something, then you get slightly better results functionally with a, therefore it's worth getting good at that. And the operative times with an uncannulated solid nail are pretty short and simple to do. So those the results were more significant until this one patient fractured. He's not actually published this paper yet. He's decided to extend it. He's added another 200 patients into each group. And so far, the results are a lot more significant, but we'll wait for further follow-up on that. They haven't got a long enough follow-up to be able to comment.
Okay. Is this a single surgeon serial?
He was... he wasn't the primary surgeon in all of these operations, but he was directly supervised any trainee that worked with him. Most of them, however, were operated on by him. So yes, he was in there with everybody.
I guess the next step will be to look into it at national register level. Do you getting on with the fracture register in the UK?
Yes, he has set that up, or he's in the process of setting it up. I think he's now the government advisor for fracture neck of femur in the UK, so he is setting up the database for that.
In order to see it in everyday care and everyday orthopedic surgeons.
Yeah, I mean, it's perfect for a trainee to go and work with Martin Parker. He's got an absolutely enormous database of 40 years of every single patient he's ever operated on, and it just makes our job as trainees, just pouring through his data, a dream, really.
Okay.
Thank you.
Okay. Just a minute. You should not be shy, because now we are ahead of time. We have very good presentators here, so please feel free to address the presentations when you want to.
And the next is the use of proximal femoral nailing, anti-rotation for hip fractures by Kieran Singizan and Nicholas Cook from the United Kingdom.
Good afternoon, ladies and gentlemen. My presentation is on proximal femoral nailing anti-rotation. This experience is from the University Hospitals North East, UK. This is purely an idea to share our experience with PFNAs, and it's by no means a randomized controlled trial. As is important with any new or recently introduced implant, it's important to look at the results objectively and to share it with the wider world. PFNA was introduced, of course, in 2004 by AO Group. Since then, there were a couple of papers published. Our experience is, of course, a single and independent center. as we did listen from Dr. Wolfson earlier this afternoon, PFNA is at least biomechanically considered to compact the bone in the femoral head rather than removing the bone, and henceforth the company preaches that it's better with osteoporotic bone. It's got a medial lateral curve of about 6 degrees, and there is a flexible tip. Benefits obviously biomechanical advantage with a nail, as well as the PFNA blade giving an advantage in osteoporotic bone. You could use a long or a short nail, depending on individual preferences and what the fracture merits. And over a period of 2 years, we looked at 68 fractures, which were dealt with 68 proximal femoral nailings, out of which some were long nails. Most of these fractures were osteoporotic or fragility fractures. The average follow-up period was 1 year, and we used a AO Trochanteric Fractures classification to evaluate these fractures, and we did look radiologically at these patients' x-rays measuring tip apex distance as well as a neck shaft angle. 2 independent observers looked at these radiological parameters, and we took an average of the 2 independent observer reported values. Of course, we had a wide range of patients. As I said, most were fragility fractures in elderly people. Average age of patient was 80 years, but it was from 47 to 100 years. Females, 38 patients, and males were 18 patients died during the follow-up period, which makes about just over 26%. We had to do open reduction in 8 patients, in which we put in circular wires around the fracture as well, and we used 6 long proximal femoral nailing amongst the 68 patients. And that's just a split up of the 18 deaths which were reported. We use the AO classification, which is self-explanatory from this picture here. Of course, A3 is more complex fracture. You would have a difficult fracture pattern, and it's very obvious that you would prefer an intramedullary nail. A1 is a less complex. Probably most of us would use a DHS. When we looked at the fracture config, most of our indications were either A2 or A3 fractures. Radiologically, we looked at the fracture reduction as well as the tip apex distance. Fracture reduction, i.e. we looked at the neck shaft angle comparing with the uninjured hip. Now, there were, of course, cases where there was no possibility of us to measure the uninjured neck shaft angle, where we either looked at the previous x-rays from our archiving system or just took an arbitrary figure of 130 degrees. If you look at the picture on the left, of course, that was not an appropriate or an optimum fracture reduction, and on the right, possibly that was considered an optimum reduction. We calculated the angles and took an average between 2 independent observer values. A lot has been said about tip apex distance. We looked at the tip apex distance on our 68 procedures. We took an AP value and a lateral value, and we took consideration for the magnification and took an average again. When we looked at the radiological parameters in our series, the average tip apex distance was 12.7 millimeters. That, of course, is half the value of 25, because 25 is a mix-up of AP plus a lateral view, and in each view you would expect it to be less than 12.5 millimeters. Average loss of fracture reduction was 7.25 degrees. Union time was about 5 months. That's an average. This is just an example of a straightforward fracture which you would prefer to nail. Of course, goes into healing without any problems, but not all patients who had PFNAs went into this kind of a situation. And the idea of this presentation was to share our experience, and we of course had 6 reoperations in our 68 patients, which brings us to a figure of just over 8%. One patient needed a revision of a short to a long PFNA for the fracture at the tip of the nail. The patient of course had a fall in the early post-operative period, so I couldn't really blame the implant for that, I believe. 2 patients needed a complex total hip replacement, and I'll show you the x-rays in a second. One, in fact, had an implant failure, and we eventually went in and did a total hip for that patient. And interestingly, though the manufacturers advocate that the PFNA blade is designed to prevent penetration, we did see 2 patients who had penetration. One patient needed a reoperation for a non-union with bone grafting. This is an example of a patient who needed a reoperation, a complex hip injury, did a proximal, long femoral nailing with a circular wire. 8 months down the line, showed implant failure. We don't know why, but we eventually went in and did a total hip. Patient did fine after a total hip. This is one more of the reoperation group patients who had a cutout, went in and did a total hip later on, did fine after that. We did have other forms of problems with proximal femoral nails. One, of course, a fracture at the tip of the nail, and one, a penetration. It's difficult to draw any definite conclusions from any single cohort without a randomization attempt. But certainly we feel that PFNA was a useful implant, and it gave a predictable result in unstable trochanteric fractures. When we looked at the fracture reduction and tip apex distance between the ones which failed and ones which went into union, it felt that the ones which failed obviously had a less optimum fracture reduction and a tip apex distance. But then I couldn't really give a definite conclusion on that because it doesn't satisfy the statistical significance. But I could come to an impression that quality of fracture reduction and tip apex distance seem to predict the results of PFNA. That's about it. Thank you.
Any questions? Yep.
Presentation. And I wanted to ask about the post-operative weight-bearing status allowed, and also whether this was correlated with occurrence of either cutting out of the screw or fracture. Thank you very much.
All patients were mobilized full weight-bearing after the procedure. There was no restriction on the weight-bearing status. So it's difficult for me to conclude either way. So yes, 6 patients underwent reoperation, but I couldn't conclude whether that's related to weight-bearing status because we didn't have any patient who was not weight-bearing. But certainly one fracture at the tip of the nail had a fall on the ward in early post-operative time. So related directly to the implant itself, but that's certainly a reoperation.
I have 2 questions to you.
Sure.
I've noticed one of your fracture complications that occurred at the proximal part of the nail was in a case where you had open reduction with the cerclage wire.
Sure.
Do you think the fact that you use cerclage wire and more extensive maybe open reduction contributed to the fact that fracture did not heal as friendly and caused eventually the mechanical failure of the implant?
That's certainly a thought because open reduction by definition would put the blood supply to the bone in a problem, and that leads to non-union or a delayed union, and there's obviously a race between the implant and the bone healing. And we did think that it's possible in this situation the nail failed because the bone did not heal, and part it was an open reduction rather than a closed reduction. Yes, that's a thought.
Do you think cerclage wire may be a factor, or if you use it, it's better to remove it, or does it make any difference whether you retain it or remove it?
I certainly can't conclude either way with my series, but my thoughts are that if we do an open reduction, certainly it puts the blood supply into some problems, and they tend to have a delayed union. And the other thought could be that we do a cerclage wire in more complex injuries, and they by definition would take more time to heal, and certainly there's a chance of subtrochanteric fractures to go into non-union. So there's a lot of confounding factors, so it's difficult for me to conclude.
Right.
First, thank you for the interesting and well-presented talk. I want to ask you something regarding the surgical technical point of view. When you insert the leg screw, at the final stage, you have to hammer it down. Did you experience any loss of reduction at that moment?
That's an important tip in the surgical technique itself, and the company itself advocates in the manual that intraoperatively, when you actually bang the PFNA blade into the head, it's quite important to keep a close eye on the fracture reduction. We did make sure that people who did this operation were aware of that fact, and we did take intraoperative images to make sure that the fracture reduction hasn't been lost. That said, though, there were patients who had loss of fracture reduction, and certainly we thought that that predicts the outcome, but I couldn't conclude either way. Yes, that's an important tip while putting a PFNA. Yes, I agree with that.
But did you experience any case like that?
As I said, we were aware of the fact that when we put the PFNA blade, there is a scope that the action will be lost. And that's the reason we took extra measures intraoperatively to make sure that that doesn't happen. Yes, but I would suggest that that is a problem with PFNA, and you need to consider that fact and take that into account while doing it.
Thank you.
Thank you. Thank you very much. Oh, last question.
One basic question to the speaker as well as to Chairman, sir. That in unstable fractures, 3-part or 4-part, you also showed slides of Evans classification. There is a big posteromedial void. The femoral component has just, the distal fragment has just a beak. And if at all you sometimes open this fracture, this void is quite big. Even you can put in your fist. My question is, when you decide to use an implant, intramedullary or extramedullary, how do you address this void, and how do you overcome the shearing forces in unstable fractures?
God, I wish I would understand what.
And certainly because of the posteromedial comminution, my experience tells me that if it's a posteromedial comminution, that basically makes it unstable, and you would have a tendency to put an intramedullary nailing device rather than sliding hip screw device. People would advocate putting bone graft if there is a posteromedial void, but we haven't done in our case series, so I couldn't really comment much on that. I don't know what the chairman feels.
Sorry?
Okay.
Thank you.
Thanks.
Thank you very much. No, oh, you're right. Yeah.
My fault. I looked at the time wrongly, so we have to. But we are going to listen to a study from Egypt, comparative studies between dynamic hip screw and proximal femoral locked plate in the treatment of intertrochanteric femoral fractures with distal extension into the shaft of femur, Arafat and El Mabou.
And I'm not going to listen to you anymore. I'm just kidding.
I am Walid Arafat from Egypt. My presentation today about intertrochanteric fractures are one of the most, those fractures which we perhaps start operating from our days of residency. These fractures carry special attention, although they are frequent and common because they are prevalent in elderly population, low energy trauma in weak osteoporotic bone, metaphyseal comminution, lack of medial buttress, and patient with associated comorbidities. Factors influencing outcome: uncontrolled like the fracture geometry, the bone quality, and the surgeon controlled factors like quality of reduction, implant placement, and the implant selection. I need to get this right, and this was the aim of our study. The sliding hip screw fixation is quick and straightforward, and it utilizes controlled impaction during weight bearing to stabilize the fracture, thus facilitating healing. However, the functional results following fixation of intertrochanteric fractures with a sliding hip screw in osteoporotic bone are sometimes unsatisfactory because of failure of fixation or failure to re-establish acceptable hip biomechanics. The locking compression plate was introduced in the 21st century as a new implant that allows angular stable plating for the treatment of complex, comminuted, and osteoporotic fracture. Despite promising results with the use of locking compression plate for complex fractures in different anatomic regions, until locked plating had not been applied to treatment of unstable proximal femur fractures. Proximal femoral locking plate versus DHS fixation, this was the aim of our study, was to conduct a well-controlled prospective randomized of 60 patients with type 4 intertrochanteric with subtrochanteric extension according to Boyd and Griffin type 4 with either a dynamic hip screw or proximal femoral locked plate, and they are followed up for 18 months. Our result shows that the proximal femoral locking plate has less fluoroscopic time, 3.15 minutes, compared to the dynamic hip screw, 5.15 minutes. The estimated blood loss was less, it was 200 cc compared to 300 cc with the dynamic hip screw. No hardware failure have been observed with the proximal femoral locking plate group, while 11.5% in the DHS group, and revision of fixation was done by the proximal femoral locked plate. Of course, if we restrict to the tip apex distance of Baumgartner, this complication does not happen. The advantage of the proximal femoral locked plate differs from the DHS in that it has more telescoping screws rather than the single DHS screw. It is argued that the more screws offer additional rotational stability and they reduce rotational torque, allowing more efficient controlled fracture impaction and reduces the risk of femoral head cutouts. Secondary varus collapse was less in the group treated with the proximal femoral locked plate. This may be due to multiple points of fixation in the proximal femur. Furthermore, DHS, when used in unstable intertrochanteric fractures, cannot adequately prevent secondary limb shortening after weight bearing due to lateralization of the head and neck fragment from gliding along the screw. In reverse oblique fractures, because of the fracture geometry, these fractures are more prone to failure when fixed with traditional sliding screw. The shaft displaces medially and the fracture does not compress as the screw slides. In our study, we did not face such a complication when these fractures were fixed by the proximal femoral locking plate. So we don't recommend to use the DHS in this type of fracture. This plain X-ray shows a medial displacement which has happened in the distal part of the femur, and the failure of the hardware which has happened. The same pattern of fracture when fixed with the proximal femoral locked plate. As regarding the dynamic hip screw, has the following advantages. The mean duration time in minutes was less. It was 35 minutes compared to 60 minutes with the proximal femoral locked plate group. Mean duration hospital stay was 5.3 days compared to 7 days. Infection rate was less. It was 1 regarding to 4%. Mean full weight bearing in weeks post-operatively was 7 weeks regarding to 7.5 or compared to 7.5 with the proximal femoral locked plate group. This is 55 years old male after a motor car accident, post-operative x-rays with fixation with long DHS. This is another case with the same fracture pattern. This is the last follow-up x-ray after fixation with dynamic hip screw. Overall, there were no difference in the rates of functional recovery between the two fixation groups. The Harris hip score showed no significant difference between the two groups. Our conclusions was that the DHS may still yield good outcome, but DHS should not be automatically the first choice for treatment. Our results indicate that intertrochanteric fractures treated with proximal femoral locked plate have similar outcomes and near statistically significant lower failure rate compared to this. The proximal femoral locked plate represents a feasible alternative for the treatment of unstable inter and subtrochanteric fractures. They offer excellent stability and rotational control in complex fractures and can offer valuable salvage options for failed fixation of other devices use. Thank you.
We will leave the questions, if you don't mind, please, after Dr. Waddell's presentation in light of the time. Is that okay? Thank you. And the next presentation is a biomechanical analysis of lag screw position in the femoral head for cephalomedullary nails used to fix unstable peritrochanteric fractures by Dr. James Waddell, Paul Kuzik, Zdero Radovan, Suraj Shah, Michael Olson, Gordon Higgins, and Emil Shemich from Toronto, Canada.
Thank you. I apologize for how mechanic paper at the end of the session, but I think you'll find it interesting that a lot of the discussion today has been about lag screw position. And you've heard a little bit about tip to apex distance in all the previous talks. And this project actually came about because of a paper I heard about 18 months ago where someone stated that in intermedullary nails, the tip to apex distance was probably not as important as in the sliding hip screw because of the additional stability of the nail. And this is important, I think, because as you all know, it's more difficult to guide the hip screw through the nail because of the fixed angle of the screw of the hole in the nail, plus the tremendous variability of where you'll find this hole depending on how you put the nail down the femur. So the question that we asked with this project was, first of all, does lag screw position in the femoral head influence the biomechanical properties of a cephalomedullary nail? And secondly, are there radiographic measurements that correlate with the stiffness or load to failure of the nail? In other words, can we look at the x-ray and predict what problems that patient might have? This experimental design involved synthetic or sawbones femurs. You can see on the picture how we created an unstable intertrochanteric fracture. Stryker supplied long gamma-3 nails for the biomechanical testing. And we looked at 5 different lag screw positions within the head. Here you see the femoral head cross-section, and we looked at superior, inferior, anterior, posterior, and central. And we were able to look at the position as you see in the diagram here. Now, the radiographic measurements, as you see on this slide, you can see the standard tip to apex distance as described by Baumgartner, and the lines that you draw to try and calculate the tip to apex distance. In addition to this, we also modified this by what we call the calcar-derived tip to apex distance. And this is important, I think, as you'll see subsequently in our discussion. So you draw a line parallel to the calcar on the AP film and measure that distance to the tip. There's the classical tip to apex distance. This is the calcar-derived tip to apex distance, which we think is important in predicting the outcome of or the fate of these nails. The mechanical testing was pretty straightforward, axial, lateral, and torsional, and we finally conducted a load to failure in all specimens in the axial position. The testing was done at the Biomechanics Laboratory at St. Michael's Hospital with an Instron machine, and you can see how the testing was performed on this slide. We looked at the slope of the force versus displacement curve to try and determine the amount of force being used, and the load to failure was conducted at 10 millimeters of displacement. The statistical analysis was pretty straightforward. Analysis of variance to compare the stiffness and load to failure, and a linear regression analysis for the radiographic measurements. These are the results, significant at P less than 0.05. And you can see that when you look at the lag screw position in the femoral head and look at the axial, lateral, and torsional results, The inferior lag screw position on the axial testing was superior or statistically significantly better than superior, anterior, or posterior. On the lateral, when you look at lateral bending, there was no significant difference in the screw position in any of these, and with torsional, superior was significantly inferior in strength to all other screw positions. So axial stiffness was significantly greater in the inferior lag screw position than superior, anterior, or posterior. Torsional stiffness for the superior lag screw position was significantly less than all other lag screw positions. We think it's important because most of these hip fracture devices fail in rotation. They don't fail actually in axial weight bearing, they fail in rotation. And so anything that diminishes the torsional strength, I think, is important in the success of the device. Load to failure, interestingly, showed that the superior lag screw position was very strong, and you'd expect that because it was immediately supporting the femoral head. It was not, however, statistically superior to central or inferior. So superior and central lag screw positions had significantly greater mean to load failure than anterior or posterior. Catastrophic failure occurred as a result of cutout of the lag screw through the femoral head, which of course is what we see clinically with settling of the fracture. Large series published in 6 years ago showed a 4% incidence of lag screw cutout, and that's been referred to in previous papers this afternoon. When we look at the radiographic measurements, we find that the calcar-derived tip-to-apex distance shows axial stiffness correlation at the highest level. And with the lateral position, load to failure correlated again with tip-to-apex distance on the lateral X-ray. The study was adequately powered except for lateral stiffness, but we don't think that is important in the testing because there is so little difference between the different specimens. So the conclusion is that the position of the lag screw in the femoral head does affect the biomechanical medullary nails, just as it does the biomechanics of a sliding hip screw. The inferior lag screw position produced the highest axial and torsional stiffness and was not significantly different in load to failure, so we feel that it's important that the lag screw be positioned either inferiorly or centrally on the AP X-ray, and if it's excessively anterior or posterior on the lateral X-ray, you have the lowest stiffness and the least strong in terms of load to failure. So we think the radiographic parameters correlate with the biomechanical properties. The calcar-derived tip-to-apex distance shows a significant negative correlation, as does the central position on the lateral X-ray. The clinical relevance of this is obvious. If you have an inferior placement of the lag screw on the AP X-ray and central placement on the lateral X-ray, you're going to maximize the biomechanical properties nail, and this lag screw position is obtained by minimizing the calcar-referenced tip-to-apex distance. Thank you.